or any one of you from Penang? None. Ada ke? Okay, tak mengaku. Okay, no problem. Okay, so IPPT is one of the youngest campus for USM. So we have Kubang Krian, we have main campus Indo, and we have Trans Krian. So basically, IPPT is the stand for Advanced Medical and Dental Institute. So we have almost all the facility that available in Kubang Krian, but in the small scale. And basically, we are more focusing on the certain niche area. Okay, not like Kubang Krian for the hospital.
This meeting is being recorded.
So I think okay, that's all for the quite short introductions about myself. Okay, so tonight we will have a seminar about child with seizures. Okay, that will be presented by your friends Huda, Khairul, and Sab. So I hope you are allowed to ask any question to the presenter. Allowed to ask any question, and I hope that tonight discussion will be a very dynamic and interactive between all you guys. At the end of the day, the objective of our discussion for you to understand about the approaches for a children with a seizures. Okay, so you all is a third year student, right? And basically, the main approach for the third year student in clinical years are the history and as well as the physical finding. Okay, that's the most important part or learning outcome during your third year. Okay, so I think without further delay, I will like Huda to continue with the presentation. Okay, Huda.
Okay, Doctor. Thank
Huda ke
you.
siapa? Huda mula-mula dulu.
Uh,
Okay. I sebut nama you sebab you yang the first in the slide. Okay, proceed.
alright. So I am Huda, and along with my friends Kai, Aida, and Sabrina, will be presenting about the child with seizures. So here are our approach to seizure. Here are the list of the questions that we are going to go through. First one, is this a seizure? If a seizure, is this provoked? If provoked, what type of seizure is this? Is this epilepsy? What is the epilepsy type? Is there an epilepsy syndrome? What is the etiology? And what comorbidities are present? So here are the framework for the classifications of the epilepsy from the International League Against Epilepsy, ILAE. So here are our frameworks. So I will pass on to our first presenters, Guy.
Okay, so Assalamualaikum and good evening to Doctor and my friends. So before I start my presentation, firstly I would like to introduce to everyone what is the definition of seizure. So according to UMPAD's first edition, seizure means clinical event in which there is sudden disturbance of neurological function in association with abnormal or excessive neuronal discharge. Next slide please. So before that, I want to explain a little bit about this diagram. So seizure will be divided into two, which are non-epileptic seizure and also epileptic seizure. So under non-epileptic seizure, it could be physiologically or non-physiologically, but we will not go into detail for this one. As for the epileptic seizure, it also divided into two, which are, like Huda said before, it could be provoked and it can also be unprovoked seizure. So later for unprovoked seizure, it will divide into another two, which are generalized category and also focal category. Next slide, please. Okay, so as a doctor, we should know that when a patient come into the ward or to the clinic, with features of seizure, for example, jerking, loss of consciousness, upward deviation of eyes, drooling of saliva, and also pupillary dilation, we should know that whether these features actually show that this patient having a seizure or actually it is a non-epileptic event. So to make sure that we do not misclassify, we have to take a detailed history regarding the seizure episode, starting from the aura, ictal, and also post-ictal phase. Usually, history of incontinence and tongue biting are more suggestive of a seizure instead of non-epileptic event. So, what are the difference actually between epileptic seizure and also non-epileptic seizure? So, for epileptic seizure, there will be abnormal electrical discharge, while for non-epileptic seizure, there are no abnormal electrical discharge. And epileptic seizure usually of physical origin, while non-epileptic seizure will be of psychological origin. So the importance to know whether it is epileptic or non-epileptic are usually because for the treatment for epileptic seizure, we will have to give the patient anti-epileptic drugs, while for non-epileptic seizure, of course, we don't have to give the patient any anti-epileptic drug. And for the EEG, there will be abnormal EEG reading, which is epileptiform pattern in epileptic seizure, while the EEG reading in non-epileptic seizure will be normal. So for epileptic seizure also, it can occur during sleep, while usually non-epileptic seizure does not occur in sleep. And the epileptic seizure also happen suddenly, while non-epileptic seizure can happen gradually. So as a physician or a doctor, to make sure that we do not misclassify these two, we have to perform complete physical and also neurological exams. We have to take patients' comprehensive history of medical, neurological, and also psychological help. We must study the result of any prior diagnostic testing, which means that if the patient before have seizure before this, we have to consider and study the result of the prior testing, which can include blood work, brain scan, and also any
আমি
prior
সিলেটে গেলাম আর রেসবা নিয়ে
CT.
গেছিলাম আমার সব শেষ করে ফেলছি রাতে কি তুই 3টায় পাইছিলি দাগ এবার কতক্ষণ পর পর হয়তো হয়
So then we also have to review response to any prior anti-seizure medication if this patient had seizure
এখানে
episode
আমাদের ইচ্ছে
before.
একটা আছে
And lastly, we have to ask family and friends who witnessed
Card.
the seizure, because we know that the child could be loss of consciousness, or maybe he or she does not remember what happened during her or his seizure episode. And next slide, please. So these are the common seizure mimics, or also known as non-epileptic seizure. So in neonates, there would be jitteriness, or usually this jitteriness, we can see that the patient having hypermotility or tremor, and it can affect more than one limb, which can switch side from event to event, which means that maybe the first event it involves another limb, and then the next one it involves another limb. And it can often separate in non-anatomical pattern. For example, first it occurs from left leg and then it goes to the right arm. And the second mimic would be benign neonatal sleep myoclonus, where this myoclonus can occur for more than one limb or the face, and usually it will occur in brief flurries lasting less than 3 to 5 seconds with pauses of variable duration. So flurries means brief period of excitement. And this also can occur in sleep and will diminish when the patient wake up. The next one would be hyperexphasia, where the patient maybe have excessive startle reaction to sudden unexpected noise or movement or touch. So usually in infancy, babies are hypertonic but not spastic, where this at times can be associated with other symptoms such as apnea and also stenosis. Next slide, please. So moving to the next age group, which is infants. So the first one would be breath holding spells, where the child possibly will hold their breath, and this usually will be triggered by pain, crying, and also fright. Children usually will cry, but this crying also can be absent with pallid breath holding, which means that the child will look paler. And then this child usually will hold their breath at the end of expiration and then becomes briefly tonic. And this usually will associated with stenotic or pallid. The next one would be benign microness of infancy, where there will be brief jerking of more than one limb. Duration would be lasting less than 5 seconds without altered awareness. And the next one would be shuddering attacks, where the child will have a brief stiffening with shoulder shaking like shivering without altered awareness, and this is also often provoked by excitement or frustration. And the last one would be Sandifer syndrome, where the child will have back arching, dystonic posturing of the limbs, and turning or tilting of the head. And this can be provoked by feeding and also lying flat, and can be alleviated with sitting up. And next slide, please. The next mimics would be in children, where vasovagal, the first one would be vasovagal syncope, where this is usually triggered by prolonged standing dehydration, change in posture, warm environment, and emotional upset, where maybe the patient get upset when their blood was drawn. And this usually preceded by lightheadedness, blurred vision, ringing in the ears, failure, diaphoresis, and also abdominal discomfort. So there will be loss of tone and can be followed by brief myoclonic jerks or tonic posturing. So usually the patient will have rapid return to awareness but can remain lightheaded for a brief period after the episode. So that next one would be benign paroxysmal vertigo, where the patient will have sudden sensation of spinning, uh, like they feel like they are spinning, and this usually occur due to abrupt onset of anxiety, and also they can feel off balance. Usually can be associated with nystagmus. The third one would be tic disorder, which is involuntary, sudden, rapid, repetitive, non-rhythmic, simple or complex movement or vocalization, which can often occur multiple times per day. And these are interruptible and can be suppressed, which means that we can try to stop the child from having this episode, but often can only be stopped for a matter of seconds. And the last one would be parasomnia, which is we commonly know as a sleep disorder that can involve unusual physical event during sleep, such as night terrors, sleepwalking, confusional arousal, and usually these will arise during deep non-REM, which stands for rapid eye movement sleep, and most commonly it do happen in the first few hours after the patient fall asleep and can last longer than 3 to 5 minutes and occur intermittently, which means that maybe the patient sleep for 1 hour and then they will have few episodes of this parasomnia. Next slide, please. So the last one would be in adolescent and also young adult group. The first one would be cardiac syncope, where there will be the patient will have sudden loss of consciousness with failure, atonia, or tonic posturing, and this often triggered by fright, exercise, surprise, and also immersion in water. And for cardiac syncope, usually family history can be present. The next one would be narcolepsy, which is also a sleep disorder, then can make children or patients very drowsy during day, which means that excessive daytime sleepiness, cataplexy, which is loss of tone in response to strong emotion, and hyponagogic hallucinations, which mean that they will start having hallucination before they fell asleep. And the last one would be sleep paralysis, which is very common, where usually we cannot move our muscles, even though we cannot move our muscles as we are waking up and also falling asleep. And the next one would be periodic leaf movement of sleep, where patient would have repetitive stereotype flexion of toes, ankle, knees, and hips during sleeping and can be resolved when they wake up. So the last one would be psychogenic non-epileptic seizure, PNES, which divided into two main semology, which are unresponsive period without motor phenomena, which means that they maybe stare blankly, but the other motor part does not go rigid, does not go tonic or anything. And the second one would be motor phenomena with irregular jerking and also thrashing. This PNES usually prolong more than 15 to 30 minutes and will have minimal post-ictal phase and also will have frequent and refractory from onset. And next slide, please. So then we move to that. If we already know that it is a
Okay,
seizure,
Nisa,
yes,
Karun, okay,
right.
Karun Nisa.
Yes.
Okay, let's go back to the slide before you proceed with the provoked seizures. Okay, so okay. After that, after this slide, next slide. Okay, so I think this is a very simpler way. Okay, starting from units, simpler way, describing seizures. Okay, starting from units, infant, children, and adolescent. Okay, you can find out many description, and this description of common, I mean, seizures that happen in infant units is always can be asked during MCQs, for MCQs. Okay, however, okay, Nisa, is it easy for you to remember all these type of seizures?
Maybe maybe one or two only, doctor.
Maybe one and or two. Okay, okay, towards from neonates, infant, children and adolescent, what are the common manifestation? Whatever lah, breath holding spell ke, Sandifer syndrome, Okay, proceed. Apa lagi? Infant and in children. Next, children. Okay, benign paroxysmal vertigo, tic disorder, blah blah blah. Okay, what are the common features that you can see? Isa?
I think jerking and hypertonic, doctor.
Hmm?
Jerking.
Jerking. Okay, I would say a simpler way is abnormal body movement, right?
Yes, doctor.
Okay, abnormal body movement. Okay, why this abnormal body movement happen? Why? Because of the definitely contractions of the muscle lah. Betul, Misa?
Yes, doctor.
Okay. And what another characteristic that you can see throughout all I mean, throughout all the syndromes, okay, of seizures that you mentioned. Apa lagi? Okay. I mean, abnormal body movement.
Um,
Okay.
loss of awareness, doctor.
No, it is a sudden, isn't it?
Yes,
Okay. It is a sudden, okay. Sudden, abrupt onset or whatsoever, isn't it? Okay, okay, so that's why sometimes when you read textbook, sometimes you might encounter a few terms, convulsion, fits. Okay, what do you think the difference between between all these terms? Convulsion tu apa? What is convulsion? What's the difference between convulsion and fits? And what is seizures? Anyone other than Nisa that want to try? Adakah? Ah, Huda?
Yes, doctor.
Ah, Pernah ke dengar term-term yang I sebutkan tadi? Have you ever heard convulsion, fits, seizure,
Hmm.
kan? Ha, what it means? Sometimes
Convulsion.
you may heard apa pernah baca non-convulsive seizures. Convulsive seizures. What is that?
Doctor, I would like to add from what
Siapa
I
tu?
read, it, Daniel Arif.
Okay, Daniel, yes, proceed.
Yeah, it it's basically referring to generalized tonic-clonic seizure, means a patient which have simple febrile fit, mean they have generalized tonic-clonic, means they have the presentation of tonic and also have the presentation of clonic, and it's generalized. It happens throughout the body. That's for
Okay.
fit. For convulsion, I'm not sure about the definition of convulsion, but
Hmm.
I think it can be used interchangeably, or it's not. Correct me if
Hmm.
I'm wrong, doctor.
Hmm. Okay. Okay. Definition fits I mean you tell is okay near to my answer. Okay. Convulsion is just a general term, it just mention about the sudden, violent, abnormal body movement caused by contraction of muscle. So you must remember, okay, it is a manifestation of sudden abnormal movement. Okay, it must it is not necessarily due to cerebral dysarrhythmias. Okay, it can be other causes than that. So that's why we can say that not all convulsions is okay. All convulsions is not necessary an epilepsy. Faham tak? Okay, and there might be an epilepsy that is not convulsive. Faham tak? Okay, it's especially when the epilepsy happening at the brain area, at the brain level where there is a cerebral dysarrhythmias without manifestation of muscle contraction. Okay. Okay, another issues that I would like to ask to siapa Nisa. Okay, and I mean you keep mention about tonic, chronic, sometime I heard about atonic. So what is that? What you understand by tonic?
Actually, that one, Doctor, I will explain
Ah,
later on.
okay. Oh, you akan ada.
Yes.
Okay, that's good. Okay, tak apa. Okay. Okay, tak apa. Proceed. Apa ni? To the next, apa ni? To the next slide.
So once we know that the patient has seizure, so we must know that whether it is provoked or unprovoked. Simply said that provoked means that the seizure will have causes or factors. So usually, patient that we met at the ward, the major factor is the patient having fever, which we call as febrile fit or febrile seizure. So the most common cause of seizure is actually high fever, and this seizure will be considered to be febrile if it occurs in children in at the age of 6 months to 5 years old, and the fever temperature is high, above 38.3 degrees Celsius. So how do usually our most common problem is that we do not know how to differentiate between simple and also complex febrile seizure. So this is the list where in simple febrile seizure, usually the duration will be less than 15 minutes, while in complex febrile seizure, the duration will be more than 15 minutes. And for simple febrile seizure, it is classified under generalized seizure, while complex will be classified under focal seizure. And for simple also, it usually does not recur during the febrile episode, while the complex seizure will occur more than one time during the febrile episode. Okay.
Nisa,
Yeah.
before that, what you understand by the statement that you have put? Okay, if it is occurred in between 6 month old to 5 years of age. What do you mean by that?
Um, the age group for febrile seizure is usually between 6 months to 5 years old. That's what, from what I understand.
So kalau you, I mean, you have a child who is 7 years old and came with fever and fit. So what is your consider?
I'm not sure.
Apa dia?
I'm not sure.
Ah?
I think maybe we can still consider it as febrile seizure, but commonly it occurs between the 6 months to 5 years old.
Anyone?
Doctor, I want to help. So,
Siapa tu?
in Daniel,
Daniel, yes, Daniel.
so in hospital setting, if the patient have seizures and febrile at that condition, when the child is below 6 months, normally we treat patient as having meningitis until proven otherwise.
Okay. How about, okay, not necessarily meningitis. It can be other causes than meningitis. Okay. The statement, 6 months to 6 years old or 6 months to 5 years old is just that to say that the prevalence of febrile seizures is only happen within this happening range of age. Okay. If it is happen away from this range of age, you must not telling us that this is probably a simple febrile seizure or complex febrile seizures. Okay, you have to exclude other differential diagnosis. Okay, that is most likely like meningitis, you know or else. Okay, anything, a lot of apa ni causes can be put under apa ni seizures. Okay. And Nisa, what you mean by otherwise a healthy brain may provoke seizures in children with otherwise healthy brain? What do you mean by that, Nisa?
That that means that the patient does not have any brain problem before the seizure episode.
Let's say you have a 3 years old boy. Okay, 3 years old boy who had cerebral palsy and came to the ward um, with fever and seizures, fever and fit. What is your conclusion? Isha,
Could it be that the cerebral palsy can wait,
would
he's
you
having
like to label this child as a febrile seizures?
I will have to check. Oh, he has fever too, right? High fever.
Dia demam.
Okay. So I think
You see, but this child had some brain insult, or probably, okay, let's say the child have history of uh, uh, global developmental delay.
I think we can still label him as febrile seizure, but this sentence actually means that fever is one of the major cause for a children with healthy brain to get seizure.
Anyone? Okay, this is a very important concept that you need to understand. Okay, number one, okay, simple febrile seizure or complex febrile seizures is just to say that there are certain people, a certain child who are simply can had a seizures because of the fever. Okay, and usually based on the study, we found out that the prevalence is between among 6 month old to 6 years old, and it must be towards the healthy children. Okay, if the child had some brain issues, okay, developmental issues, okay, never label it as a febrile seizures. You must exclude otherwise, because it can be the child is actually having an epilepsy, that that the fever is suddenly provoke the epilepsy and cause fit. Okay, so that's why to say or to label any of the child, okay, that is a possible of febrile seizure must fulfill these two important criteria. Okay, so whether you want to further classify simple febrile fit or complex febrile fit, it is based on the classification as mentioned. Okay, faham?
Yes, doctor.
Okay, proceed.
Okay, so aside from fever, these are the other causes of seizure. Firstly, infection, which can include encephalitis, meningitis, and also brain abscess. Metabolic condition, for example, hypoglycemia, hypocalcemia, hyponatremia, or hypernatremia. The third one would be poisoning, which could be lead poisoning or drug toxicity, and also drug withdrawal. The next one would be systemic disorder that could include vasculitis, SLE, and also encephalopathy. And the last one would be a parental condition, which usually is intrauterine infection. Next slide, please. So we move on to the classification of seizure type, which can be divided, majorly divided into focal onset, generalized onset, and also unknown onset. So for the focal onset, it usually involves the one part or unilateral part of the cerebral hemisphere, while the generalized onset, which will involve both sides of the hemisphere. And for the focal onset, it will further divided into aware or impact awareness. And this aware actually once called as simple partial seizure, while the impact awareness we used to call it as complex partial seizure, but I read somewhere that both terms are not used anymore. So for the focal onset, it will involve motor. So firstly is automatism seizure, which it can occur due to it can occur and cause impact cognition, where the patient will have confusion and also irritability. And the second one is atonic, which can happen suddenly, where the patient will have loss of tone. That sometimes also can cause them to fall to floor or dropping of the head. And the duration for atonic is between 1 to 2 seconds. For the tonic phase is where the patient will experience hypertonia, where we can see that the patient might arch their back, arch the trunk, and also extend their neck. The duration usually lasts in between seconds to minutes. And the next one would be clonic phase, where the patient will have jerking movement and drooling of saliva and also tongue biting at this phase. And the duration usually will be lesser than the tonic phase. And the next one would be myoclonic, where myoclonic means sudden and brief shock-like contraction, and it usually is repetitive. And the next one would be epileptic spasm, where there will be sudden flexion or extension of trunk and also extremities, and the duration would be less than 2 seconds. An example of epileptic spasm is infantile spasm, or will also known as salam spell. And the last one would be hyperkinetic, where we can see the patient having fast movement like they are thrashing and also pedaling. And the next one would be non-motor onset, which firstly is autonomic, where there will be alteration in the autonomic nervous system that could cause um, the heart rate to increase or decrease. Then it also can cause pupillary dilation or constriction. And lastly, it can interrupt the thermoregulation. And the next one would be behavior arrest, which means that maybe the child, we can see that the child having stopping pain in their behavior or action, which means that maybe they are playing, but then they start freezing or becoming immobilized. There will be cessation of the ongoing activity that they are doing. And the third one would be cognitive, where the patient sometimes will experience language or memory problem. And the next one would be emotional, where the patient suddenly will have extreme fear or joy or euphoria. Maybe they start laughing or start crying. And then the last one would be sensory, where this patient will have no appropriate external stimulus, which means that uh, if we maybe put something hot to them, they will not react to it. Okay, so the second classification is generalized onset, which I have explained the phases. And as for the non-motor, it is also known as absent seizure, where in absent seizure, there can be loss of consciousness, and patient also will stop what they are doing and start staring blankly or blinking their eyes. And there will also be, it can be atypical, and there will be myoclonic freeze and also eyelid myotonia. And the last one is unknown onset, which it is called unknown because usually there are not enough information for the doctor to classify this under focal or generalized. Okay, so I think that's all for me.
Nisa, Nisa,
Yes,
why do you think that there are such motor onset or non-motor onset?
the motor onset means that it involves the body movement. Okay.
Where is this cerebral dysarrhythmia happen? In the brain, right,
Yes.
Nisa?
Yes.
Do you still remember the area in the cortical area, which is the motor area, sensory area. Ingat tak?
Yes.
Okay. So that's why from the the history or even physical finding, we somehow can have a wild guess where is the possibility of the insult, you know. Uh, so I mean, even though that most of the time seizure will manifest as motor manifestation, abnormal movement, whether it is toning, atoning, or blah blah blah. But be careful. You must aware that there are also a non-motor onset of seizures, kan? Macam you cakap tadi kan, emotional type of seizures kan, jadi suddenly euphoria kan. Kognitif pula macam mana? Pergi exam terlupa. Seizure.
Yes. Maybe not doctor.
Okay, that I mean, kalau I mean, if you only one time tu, a few, I mean, because you're anxious or anxiety or you are not study well, then it's okay lah, normal lah. But if you come across, people who are, still have a cognitive problem, I mean, it is the best for you to do some medical checkup to look into of this issue. Okay, because it can be one type of seizure manifestation. Okay, okay, proceed.
Okay, so that's all from me. So I'll pass to the next presenter, Aida. Thank you.
So tadi Nisa, you kata tadi akan ada definisi of tonic, atonic, chronic. Dah habis dah.
Yes, the one I explained about tonic.
Okay. So I nak tanya balik lah. What is tonic?
It's the increase in tone.
What you mean by increase in tone?
The patient will
How
suddenly
you
be
define tone?
uh,
What is tone?
Tone is when it's like rigidity, doctor.
No, tone is not rigidity. Anyone? I like to ask a very simple question just to make sure that you really understand. You know, examine tone is one of the, basic CNS examination. But I hope as a third year student, you are not confused. Confused still not confused. I hope that you are not confused. Sorry. During the SEN examination. Okay, Nur Ashikin Najwa, what you understand by tone? What is tone? You were asked to examine tone, kan?
Yes, doctor. What
Ah,
I understand by tone is the range of movement.
the range of movement. Hmm, betul ke?
Doktor,
Ya,
maybe tone is the resistance. When we
siapa tu?
examine the child, Huda, doktor.
Ya, yes. What is tone?
The resistance that we felt when we examine the child joint
Uh-huh.
passively.
Huh?
That's
Ulang
all.
sekali. The resistance that
The,
you feel.
when we move the child leg passively, doktor.
Passively, okay, that's tone. Okay, tone is the resistance towards the passive movement. That's the tone. Okay, I hope you still remember, the intrafusal fiber that controlling the muscle, right? That give the muscle normal muscle tone. So the resistance that you feel by giving a passive movement, that is the tone. So that's why you should familiar what how the feel of normal tone. Okay, after you do and practice many times experiencing the normal tone, then you can appreciate what you mean by hypertonia. Okay, hypertone, what you mean by hypertonia? Huda?
Increase in resistance.
Simple lah tadi. Tadi apa ni resistance dia towards passive movement, there will be some resistance normally. But if there's hypertonia means there is increased resistance. Okay? How about tonic? What is tonic? Huda?
Tonic. Tonic
Ah,
is like tone, doktor.
tonic apa dia tonic? Tadi duk sebut tonic lah, clonic lah, atonic lah. Tonic?
The diseases that related to the resistance.
Alah, tonic is
I'm
just a
not
simple
sure,
term.
doktor.
Tonic is just a simple term for high tone lah, very high tone and cause rigidity. Okay. Okay, how about atonic? What is atonic? Udah?
Loss of tone.
Loss of tone lah kan. Atonic. What happened to the muscle? What happened to the move to the resistance?
No resistance at all.
Okay, no resistance, flaccid. You know flaccid, okay? So that one is atonic, no resistance at all, okay? Uh, or what's the difference between atonic and hypotonic?
Hypotonic is reduced in tone, resistance. And
Okay,
atonic is the chronic one.
no resistance at all, flaccid.
Uh,
Faham tak? Okay,
yes.
So that's why it's very, very important for you to understand how to feel the normal tone. Then you can appreciate what do you mean by hypertonia? What do you mean hypotonia? Okay, and what is atonia? Okay, atonic. Okay, atonic means no resistance at all. It becomes flaccid. But hypotonia, there are some resistance, but if it is hypo, it's not as normal, as a normal tone. Okay. How about chronic? What is chronic, Uda? Tonic, chronic. What is chronic?
If I'm not mistaken, Doctor, chronic is contractions.
Okay, definitely
Series.
contraction.
Series
Okay.
of contractions.
Okay, so chronic is a rhythmic muscle contraction and relaxation. So that's why you can see a movement. Betul tak? Okay, when you try to exclude you when you try to describe the history from the parent, how would be the description for tonic clonic movement? Udah? What would be the description that normally you look from the history to say there is a possible of tonic clonic movement? Anyone? Siapa kat sini lagi? Yes, Sabrina.
Yes, doctor.
Hmm. You ada experience taking history from parent, right?
Mm.
For I mean clucking seizures or fit, betul?
Yes, doctor.
Ah. Then how from the history given by the parent, how you want to conclude that there is an event of tonic clonic
Mm.
seizures or
First-
fit?
Firstly, I
What
will
would be the description by the parent?
maybe ask the parents if there's stiffening of the joints when the seizure happens.
Pardon? Apa? Ulang sekali?
There's stiffening of the joints when
Stiffening,
the seizure happens.
stiffening of the of
The
the
limbs,
limb,
limbs.
the
Sorry.
limb, and then
And then followed by jerking movements
jerking movement. What you mean
with
by
the
jerking movement?
rhythmic contraction and of the muscle.
Abnormal movement.
Normal movement. So tonic clonic
Okay.
have both, doctor.
Yeah,
Stiffening and
because if it is a tonic per se, there will be no movement at all, isn't it, Sabrina?
yeah.
Kan? Kan? If it is a tonic, how will be the description for tonic seizure per se?
Only there's no abnormal movement, just rigid posture.
Yeah, rigid posture become, spasm like condition, there's no movement. Okay, because probably if you can ask whether the muscle become hard to move and sebagainya means a tonic. Once the parent is describing about abnormal movement, okay, then you should think about chronic. Okay, because clonic is rhythmic muscle contractions and relaxation. They contract, they relax, they contract, they relax, so that's why there's a movement. Okay, atonic.
Atonic.
Hmm.
When the patient suddenly have loss of body tone, like suddenly patient jatuh.
Lembik macam tu. There's no movement. Okay, or lack of movement. Okay, during the seizure. So that can be a possibility of atonic type of seizures or epilepsy. Okay. How about myoclonus? Uh, Sabrina, have you heard what term myoclonus?
myoclonus. Not sure, doctor.
Not sure, but you heard this term, right?
Yes.
Ah, who else want to try? Navin, Navina. Yes, Navina.
Is it like a brief jerking movement, doctor?
Brief jerking movement. What you mean by that?
Like a brief contraction of the muscles for a brief period.
You mean the durations of the contraction?
Yes, doctor.
No lah. Okay. Kalau you tengok pun perkataan chronic myoclonus tu dia derive from what? From chronic kan, clonus, myoclonus. Okay, so myoclonus is a shock-like muscle contraction. You know, there will be, shock-like muscle contraction. It is a very, apa ni, how to describe, how to demonstrate. It's just a shock-like muscle contractions, okay, that happening abruptly. Okay, that you can suspicious of myoclonus. Okay, so Navina, what do you think? Is it easy for you to describe all this, description from history?
Using this term, is it, doctor?
Yes. You are the one who will club patient, isn't it? Is it easy for you to make a conclusion from the history per se to tell, oh, this is possible of tonic, clonic, or atonic, or myoclonus seizures?
I don't think so, doctor.
Okay, why?
I think we should do physical examination also to check for the.
Okay, you can support your history towards, I mean, with your physical finding. Okay, I agree. Okay, what else? Because sometimes there's I mean, there is not much physical finding that can support you to classify the seizures. So how you like to, to look into this, tonic, atonic, chronic, myoclonus?
I'm not so sure, doctor.
Not so sure. Okay. So that's why sometimes it is a very good if you, I mean, uh, if the parent can have some, video camera to rakam the event, so that we can really observe what is really happening during at that time. Or sometimes, okay, if you still have in doubt what are possible type of seizures, okay, we can do an EEG together with a video camera to induce some epilepsy, I mean, some to induce the seizures. Okay, then you can see the seizures manifestation. So by examine the video camera, that video, or the event, you can somehow classify. Okay, this is one way. Okay, is it important, Sabrina, for you to get all this clue? Tonic ke, atonic ke, myoclonic ke, penting ke?
Yes, doctor. Very
Why?
important
Why?
because the the management is different for each type of seizure.
Okay,
So
definitely management is different, but most importantly, you can go back to the classification, isn't it? You need this information to classify which is the potential classification of this epilepsy, isn't it? And within this within, if after you get the potential classification of the epilepsy, then you can propose the potential right treatment for the patient. Okay, that would be a very challenges. Okay, okay, proceed.
Hello, can you hear me, Doctor? Okay.
Boleh, boleh, boleh.
Okay, so my part is for to present about the epilepsy. So how do you know if this is epilepsy? So based on the pediatric protocols, the definition is disorder of the brain characterized by an enduring predisposition to generate epileptic seizures and by the neurobiologic, cognitive, and social consequences of this condition. So it's a bit confusing to understand the definition. So, but it's okay. We can look at the clinical definition. So there's like three clinical definitions. So so the first one will be the two or more unprovoked seizures occurring more than 24 hours apart. So if this sekali je, we would call that epilepsy. So we need two or more seizures occurring more than 24 hours apart. Or it could be one unprovoked seizure that occurred. However, there must be a probability of further seizures similar to the general recurrence risk for at least 60%. 60%. So this needs to happen after two unprovoked seizures occurring over in the span of 10 years. So the last one would be a diagnosis of epilepsy syndrome. Okay, so next slide. So just now I mentioned something about epilepsy syndrome, right? So an epilepsy syndrome is actually a distinctive clinical entity that can be we can rely to identify what type of epilepsy it is. So we usually heard about syndromes like they have like certain spectrum or like characteristics that categorize them into certain categories. So for the epilepsy syndrome, we can classify as
This meeting is
actually
being
the syndrome
recorded.
can be classified in a more detailed way, but it's a very long list, and I will share the list later on. So we can, according to the syndrome list, we can see that there's difference of age of onset, the seizures type, the imaging, like imaging changes, like the EEG characteristics. So different syndrome would have different clinical presentations. Okay, so next slide.
Aida,
Yes, Doctor.
cuba you tengok apa ni, the list of seizures tu kan. What you can find out. Many names kan. Otohara lah, West lah, Dravet syndrome, Landau-Kleffner syndrome. What do you understand by that? Apa yang faham? Lennox-Gastaut syndrome. Hmm.
Sorry, Doctor. Maksud Doctor?
Apa yang you faham? Kenapa, I mean, so many description about, classification example of epilepsy syndromes that names by, names lah macam West syndrome, Dravet syndrome, Landau-Kleffner syndrome, Otohara syndrome.
I'm not sure about the others, but like some of the syndromes, like maybe the self-limited neonatal seizures, it's like self-explanatory in the names, like it is self-limited. That means it's going to stop eventually with or without medications. I think, Doctor.
Okay, that one is the characteristic for the epilepsy syndromes. Okay, then I think that the next slide is very, very important. Okay, proceed to the next slide. Okay, yes, proceed.
So for the epilepsy, for the seizure, we have like three types: the focal, generalized, and unknown. However, for epilepsy, we have focal, generalized, and also unknown, and also combined, combined generalized and focal. Because as we know, we have more than one occurrence of seizure, right? So not all the time the seizure can be like have same presentation. So it can be combined. So that's why we have another category. So for the generalized epilepsy, so the child may have seizures in the generalized seizure onset category and commonly have generalized spike and wave discharges on the EEG reading lah. And then for the focal epilepsy, it may present with a variety of focal onset seizures. So the EEG reading may be normal or can also show some focal or multifocal discharge. So for the combined generalized and focal epilepsy, this type is used for children with that has both focal and generalized onset seizures. So these patients may have both presentations lah of generalized and focal epilepsy. So for the unknown one, where we have inadequate information for further classification of their seizures. Okay, so next slide.
Okay,
So
okay. Okay, kalau you tengok dekat sini, I think the most important thing adalah diagram dan yang you tunjuk kat sini, okay. The classification of generalized ke focal ke combined generalized focal is a clinical manifestation. You know, the seizure semiology, you know, presented as what you see towards the patient. But the most importantly, you can see that the classification of seizures or no classification of epilepsy become more complex because our knowledge in regards of the genetics, metabolic and immune is evolving. Okay, you can see that many of time, especially unexplained or unknown seizures too or epilepsy is due to certain mutation that happening that lead to the manifestation of epilepsy. Okay, proceed.
okay, so we look to the etiology of the epilepsy itself. So we have like six sub category of the etiology. However, some seizures can also like caused by more than one etiology. Okay, so for the first one is the genetic. So as we know, genetic it must be the direct result of a known or presumed genetic effect. So for the examples, it can be the childhood absence epilepsy or juvenile absence epilepsy. So next is the structural. So structural, it can be congenital or acquired. So the congenital one might be due to maybe cortical dysplasia or acquired can be caused by stroke or trauma. So structurally specific structure etiology. Maybe we don't have to give like medications, but maybe it can like unilateral mesial temporal sclerosis, it can be cured by having a resective surgery. Okay, so that's for structural. Okay, next we have the metabolic. So for metabolic, the child will have a documented metabolic condition associated with risk of developing epilepsy. So examples might be the glucose transporter deficiency or creatinine deficiency syndrome. So like I said, we can have more than one etiology, like right? So maybe some metabolic deficiency, some deficiencies symptoms can be from genetic cause as well. Okay, next is the immune. So for the immune, the child will have a clinical evidence of an immune disorder, like NMDA encephalitis or mGlu-R5 associated limbic encephalitis. And also for the infectious, we can see that it is a direct result from a known infection, like tuberculosis or cerebral toxoplasmosis, and also maybe congenital infections like Zika virus or cytomegalovirus. And the last one would be for the yeah. So for the last one would be the unknown cause, which is not currently known yet. So I think that's all for me.
Okay, Aida. At the end of the day, whatever etiology that you mentioned on this slide, Can you still remember tak apa ni yang apa the basics apa ni neural activities, you know, uh, macam you know basically our brain, our neuron, normal neuron in our brain is, you know, giving a synchronous discharge, isn't it? And that's why when you put some, you know, electrode in our brain, kita boleh dapat a normal rhythm EEG. Okay, what happened during seizures? What happened during seizures? Aida.
You mean like with the EEG reading ke?
Dengan EEG. Dia sepatutnya ada normal synchronous discharge of neuron. Okay. Because the spreadness of electrical activity between the cortical of the brain, it is controlled by what? By what? If you still remember. Apa yang control? Okay. Apa yang control?
I'm not sure, Doctor.
Neurotransmitter. Okay. The excitatory neurotransmitter and inhibitory neurotransmitter. Okay, so the balance between the excitatory neurotransmitter and the inhibitory neurotransmitter, so that this balance between this neurotransmitter can lead to normal neuronal discharge of the brain. Okay, somehow when there is you know instability of the neuron cell, ataupun sama ada the excitatory neurotransmitter tu lebih ke, ataupun the inhibitory neurotransmitter is reduced, then it will, you know, provoke the paroxysmal depolarization shift ataupun PDS. This yang boleh menjadi pencetus for the epileptic foci. Okay, so from the study, based on these two event, if you still remember, it is controlled by what? The neural transmitter production dan juga the, you know, the structures of the channel. You know, bila channel the channel of the cell yang orang kata apa, yang nak mencetuskan apa ni depolarization shift tu, kan, you still remember tak depolarization shift tu? Okay, so the channel yang nak keluar ion apa-apa semua tu, if there is a problem ataupun kita call it as a channelopathies, so this can be one of the roots of the cause of epilepsy. So why this channel become problem or got problem? So that's the genetics, you know, finding come into. Okay, faham? Faham ke Aida?
Faham, Doctor.
Okay. Okay, tak apa, proceed.
So, moving on to the comorbidities, as we can see the framework here, usually epilepsy will come with the comorbidities, and these comorbidities can be further divided into neurological, psychological, and physical. So we go one by one. For the neurological, it can be intellectual disability, where disability that are related to the IQ or the lack of skills for the child to do their daily livings, and prevalence, it can affect approximately 25% of children, and more common with specific syndromes. etc. And last is about the sleep problems. Sleeps may be affected by nocturnal seizures and also effects from medication. Next is about the psychological. First one is mood disorders, including anxiety and depression. So the prevalence of it happen about 20%, and it often coexists with other comorbidities. It can exist happen with the ADHD or others. It is have higher risk with the positive family history of mood disorders. So the etiology can also be from the genetic causes. Right. So the next one is attention deficit or hyperactivity disorders. It can stand alone, deficit alone, or it can stand the full name of it, attention deficit hyperactivity disorders. The prevalence of it happen about 30% of children with epilepsy, but without the attention deficit, without the hyperactivity is more common than the both one. And the prevalence of girls and boys are affected are equal, just the same. So the next one is autism spectrum disorders. Risk is 7.4 fold higher in children with epilepsy, and the risk factors including intellectual disabilities, the specific syndromes like West syndromes, and the specific etiologies like the tuberous sclerosis and certain genetic disorders. And the last one is physical. It is regarding the bone health. It can be due to the reduced physical activity, like the child in the wheelchair, they are dependent on the wheelchair. So the use of the muscles is reduced over the time. The bone health will be affected. And if the child is always stay in the house, so it can reduce their vitamin D because so it reduces vitamin D and sunlight exposure. And there are also effects of anti-seizure medications that can affect their bone health. So the research studies shown that 58.3% of epilepsy patients have bone mineral density problems, where 75% of it have been said has osteopenia, and 25% of it had osteoporosis. Right, so moving on to the history, what we want to get from the history taking. First, about the details of the seizure, the potential preceding aura, the post-ictal period, how long is it, the frequency of the events, the seizure occur, is it only one or more than one or more than two, so that we can classify it because it plays with the number, right? And then the duration, we can classify it into the, if it is simple fibrillation, can be simple or complex. We can differentiate between that two. Is it static, progressing, or improving? Is it can be classified either acute, subacute, or chronic? So the next step is we must get a thorough history about the developmental history. For example, the gross motor, fine motor, speech or language, and social domains. So that by this one, we can assess the evidence of developmental delay or regression. So maybe the child can have like the global developmental delay or etc. And then we must include the medication history, including previous anti-epileptic drugs. The next one is about the family history. If the patient have the strong family history of epilepsy or seizure, there will be the high prevalence of them to get as well. Family history of epilepsy, neurocutaneous syndrome. So from it, we can see like the presentation of cafe spots because it plays with the skin, neurocutaneous syndrome, migraine or neurodegenerative disorders. Next one is the past medical history, includes immunization, accidents, and chronic medical problems. And the last one is the birth history, for example, such as gestational age, pregnancy complications, including the infections, maternal drug use, the APGAR score, and the delivery problems such as meconium aspiration. Okay. So moving on to the physical
Kejap,
examination.
kejap,
Okay.
Huda. Okay, can you go back to the slide? Okay. Um, sometimes when you read textbook, there will be a detailed description on how to explore specific history towards a certain condition, blah blah blah. Developmental history lah, medication lah, family, past medical history dan sebagainya. So as a student, sometimes don't have an attempt to memorize all this thing. I mean, it is a good what you need to do adalah, okay, please go back to the diagram yang kita tunjuk tadi. Boleh tak pergi ke diagram yang ada etiologi? Yeah, this diagram. Okay, nampak tak? The idea of us to do history taking and physical finding is for us to help the patient. This is a common and logic. How to help the patient? You need to know the real root cause. Okay, why you need to know the real root cause so that you can offer the right solution. So that's why when you get a case like seizures, so it's very very important for you, number one, to describe, okay, what are the potential classification of these seizures. Okay, and then after that, try to look what are the potential etiology. Okay, and then try to look what are the comorbids, that might related to this patient, this particular patient, or what are the complication that might already happen to this patient, and so on and so forth. So this thing should be included in your history. So kalau ada semua benda-benda macam ni, then insyaAllah your history will be complete. Okay, even though that when you do history taking, you akan start as what? Chief complaint, history of presenting illness, and then followed by what? Past medical history, drug history, dan so on, so on. So benda-benda ni pun at the end of the day adalah looking into this faktor-faktor ni. Okay, so if you manage to get a potential clues ataupun reason, okay, please bring forward the facts into the HOPI. Okay, janganlah apa ni, because that one is a very very important history. Okay, faham tak Huda?
Faham,
Huda?
doktor?
Faham. What is normally happen for student? They are, so naively follow all the sequence, because sometimes, most of the time, you present the history until sampai HOPI, lepas tu, people might get bored and not focus anymore. Then they thought that, you miss most important points. Tapi sebenarnya what happen is you are not prioritizing the points and left the important points tu dekat belakang. Tak sempat you nak bagi tahu. Okay? So this is a very tricky. Practice make perfect. InsyaAllah from time to time, there will be no a direct answer on how to approach it. But when you practice, to decide what is the most important points that need to be highlighted, and what are the least important point that to be telling later. Okay? Okay, yes. Huda, proceed.
All right. So now we are moving on to the physical examination. So this is just the simple explanation. So the first step is we introduce ourselves and then assess the mental state of the patient. Patient conscious and alert. And next, we go to the general observations. We look for whether there is dysmorphic features. For example, in Down syndrome, there is upslating of eyes, hypertelorism, and in the Turner, for example, also in the Turner syndrome and Pato syndrome. Pato syndrome, we can see their cleft. Next is about the skin rashes. Examples of skin rashes are cafe ole spots in the neurofibromatosis type 1, the hypopigmented macules we can see in the tuberous sclerosis, and the facial part 1 vascular malformations in the stage Weber syndrome. Okay. So after that, we look for their posture, whether, for example, in the cerebral palsy, there are spastic posture. These are the examples of posture, opistotonic and scissoring posture. Okay. Then we look for the involuntary movement and asymmetry. Next, about the sphygmomanometer. For the blood pressure, if there is we measure the blood pressure. If there is a hypertension, increase in blood pressure, there might be the precipitating fever. Or for the Truser sign, it's signs of the hypocalcemia. So these are the signs when we occlude the brachial or radial artery with the valve, and there is the occurring of the finger and hand spasm when we do the occlusion. So it is the signs and suggests that the child having hypocalcemia. All right, moving on to the head and neck. So for the head, we measure palpate auscultate. We measure the size. We look for the evidence of microcephaly or macrocephaly. For the auscultation, we can hear whether there is any bruit. For the palpation, we palpate for the shunts. We feel for the suture, there is the skull bony defect or not, or whether the fontanelles can be felt or not. And then there are also scalp veins prominent. We look for the scars. We see the shape. If the shape of the head is examples of the shape that we can see is flat occiput and prominent forehead. Okay, for the eyes, next is for the eyes. We can inspect the eyes. This evidence like ptosis, nystagmus, and the functions of the eyes, the acuity function, the fields, visual fix, and the visual neglect, the movement of the external ocular, whether it's upward gaze, lateral gaze palsy, and the pupil, whether it's dilated or not. And then moving on to the ophthalmoscopy, next thing, there is the evidence of cataracts in the lens of eyes. And for the retina, we can appreciate about the papilloedema, optic atrophy, or hemorrhage. Okay. So, other than that, we can check for the hearing, whether the patient had impaired in hearing. As we know, cerebral palsy came with the presentation and we move to the upper limbs, we need to do both lower limbs and upper limbs to assess the motor examination. And then after that, we move on to the abdomen. We check for the hepatosplenomegaly, we palpate and percuss to see whether there is the etiological factors from the neurometabolic disorders. And then we see the temperature chart, whether the patient had fever or not, and then others are urinalysis. I think that's all for the physical examination. This one I got the reference for the pediatrics examination textbook. Okay. That's all from me. Thank you. I pass on to the Sabrina.
Okay, so I'm Sabrina. So I'm going to continue the presentation with investigation. So these are the investigations that should be done when there is the first episode of unprovoked febrile seizure. Unprovoked meaning there's absence of any precipitating factors. So the first one is hematological test. So this test should be done in order to rule out any metabolic causes. For example, first one, full blood count must be made, so we can expect uh we can expect like high WBC, white blood cell, in order to rule out any etiology of infection. Second test is blood urea serum electrolyte, calcium and also magnesium level, because in blood urea serum electrolyte, if there's any hyponatremia, it can also trigger seizure. Hypocalcemia and also hypomagnesemia can also trigger seizures. And the third test is random blood sugar or random blood glucose, since hypoglycemia can also trigger seizure. Sorry for its first unprovoked afebrile seizure, typo. Okay, so the hematological test should be done only if the child is unwell. So in this case, unwell means when the patient is having diarrhea and also vomiting, or if the patient is not alert and also lethargic. The second test is toxicology screening in order to rule out suspicion of drug exposure, since certain drugs can also induce seizure. The third one is lumbar puncture in case there's suspicion of brain infection, for example, meningitis, like when there's signs of neck stiffness and so on. The fourth investigation is EEG, whereby it can help to classify the seizure types and also epilepsy syndrome, and it also can predict if recurrence of seizure in the future. And the next one is neuroimaging. So there's two types of neuroimaging, MRI and also CT scan. But in this case, MRI is more preferred. So MRI is only indicated in first unprovoked febrile seizure when there's persisting post-ictal focal deficit, meaning after the seizure there's focal deficit, for example, thought paralysis, weakness of the limbs after the seizure, or when the condition of the child is not returned to the baseline, not returned to normal within 7 hours after the seizure. Next slide. So now is the first unprovoked. This one when this the second unprovoked febrile seizure. So the first test is hematological test, just like the same as before. Full blood count, blood urea serum electrolyte, calcium, magnesium, and also random blood sugar. For EEG, it's more uh, important in the second one to support the clinical diagnosis of epileptic seizure. And EEG can also be used to classify the seizure types and also epileptic syndrome, and helps to later on select the appropriate epileptic drug and also the prognosis. And also MRI is important And when is MRI indicated during epilepsy is when it occurs in the first year of life, or when there's focal epilepsy, when there's developmental delay, and also refractory epilepsy. So MRI is not indicated when the patient had childhood epilepsy with centrotemporal spikes, or what called as benign Rolandic epilepsy, or idiopathic generalized epilepsy, such as childhood absence, juvenile absence, also juvenile myoclonic epilepsy. Next. So that's all regarding the investigation. So now into the management of epilepsy can be divided into medication, counseling, and also management for drug-resistant epilepsy. Okay, so for medication, not all children with epileptic seizures require anti-epileptic drug therapy. So the decision should be made based on the seizure types and so on. And the treatment is recommended if the seizure is more than 2 episodes. And the preferable therapy is monotherapy, meaning using only one type of drug only. This with minimum dosage, and this is important to prevent further adverse effects. And how it should be done is the dose should be increased gradually until the seizures are controlled, or the maximum dose is reached. And if the first drug failed, then we can add on the second drug. And after we add on the second drug, we optimize the second drug and then try to make it monotherapy again, withdraw the first drug. So it is important to select anti-epileptic drugs according to the seizure types. For example, in this diagram here, focal seizures, like drugs that always be given, first line is carbamazepine and also sodium valproate. You guys can read later on for the second line. And for the generalized seizures, for example, tonic, clonic, or clonic only, the first line is valproate. The second line, the usual one is lamotrigine. Carbamazepine can also be used. For absence seizure, first line valproate, atonic, tonic, myoclonic. If you see the first line, valproate is also recommended. Okay, next. So of course, all anti-epileptic drugs has potential unwanted effects. So this should be discussed. So with the parents. So some of the adverse effects of anti-epileptic drugs is firstly carbamazepine. It can cause common side effects include drowsiness, could cause dizziness, ataxia, diplopia, and also rashes. But sometimes it can trigger serious side effects. For example, Steven-Johnson syndrome, especially patients that have a certain gene called HLA-B1502 gene. So consider testing if it's available lah, to avoid carbamazepine. Okay, clobazam, clonazepam, common side effects, usually drowsiness, hypotonia, salivary and bronchial hypersecretion. Okay, let's go to the more common ones. Sodium valproate, the second picture. So the common side effects include nausea, epigastric pain, tremor, alopecia, hair loss, weight gain, thrombocytopenia. But it can also develop some serious side effects such as hepatic toxicity, pancreatitis, and encephalopathy. So we should consider sodium valproate in female of childbearing potential. Selalunya kena avoid because this drug has risk of heterogeneity. Okay, so for the third picture, it is very important actually to choose an appropriate anti-epileptic drug because inappropriate ones may be detrimental for the patient. For example, like The first one phenobarbital, like it's very effective in focal seizures, but it's very bad for absence seizures. It can trigger absence seizures. For example, the third one, the common one, carbamazepine, it's the first line for focal seizures, but just for focal seizures. But if it's used in absence, myoclonic, generalized tonic seizures, it may worsen the condition. So that's why we need to diagnose the seizure types carefully, because wrong drugs, bad prognosis. Okay, so I think next. Just now for medication, this time is the management for counseling. So it's important to educate and counsel on epilepsy, especially on the patient themselves and also their parents. They must be taught or educated on the first aid measures during a seizure. And secondly, counsel regarding emphasizing compliance is on anti-epileptic drugs. This is very important because if they were to suddenly stop the medication, it can precipitate the seizure, where it's called breakthrough seizures. And if we must parents must know, and the patients themselves must know the trigger for their seizures. In case if the trigger is caused by photosensitivity, they should avoid the trigger lah, meaning watch TV in brightly lit room and also avoid sleep deprivation, and use a shower with bathroom door unlocked, just in case of sudden onset of seizure. No cycling in traffic, climbing spots, or swimming alone should be avoided, and educate on the emergency treatment procedures. And the condition of epilepsy of the patient should be informed to the teachers and also the school, so they will be more ready about if there's a sudden recurrence. Next, regarding the management of drug-resistant epilepsy. So drug-resistant epilepsy ni meaning the patient fails to become seizure-free after trials of two different types of anti-epileptic drugs. So this kind of patient should be referred for more alternative treatment. So some of the alternative treatment includes possible epilepsy surgery, like colostomy or neuromodulation. But this is usually more macam last line lah. Next is consideration of additional therapies. For example, dietary therapy such as ketogenic diet, because it has been shown that ketogenic diet can actually reduce the recurrence of seizures by 50%. So ketogenic diet ni maksudnya diet yang high in fat and low in carb. The other ones too, modified Atkins and glycemic index diet can also be. So I think that's all from regarding the management. Okay, thank you.
Okay, habis dah ke?
Dah, Doktor.
Yes, Doctor.
Okay, ada soalan? Okay, the part of the management, whether you want to use apa ni pharmacotherapy or non-pharmacotherapy can be further discussed later on. The choice of apa ni drugs, anti-epileptic drugs dan sebagainya. Okay, so but now I will be more focusing on the history and physical examination in approaching for epilepsy or seizures. Okay. So ada soalan ke? Tak ada soalan untuk presenter. Presenter ada apa-apa nak tanya? Okeylah, Huda. Huda? Okay, Huda. This is an OSCE question. Okay, you were asked to advise Sabrina, okay, on apa ni, advice Sabrina, tak menggunakan Sabrina lah, advise a mother yang mana I mean the child will be discharged of first admission of simple febrile fit, and she will be discharged soon, in this afternoon, for example. And what would be your advice to the parent? Okay, please advise to Sabrina. Imagine Sabrina is a parent. Yes, Huda. Huda?
Yes, Doctor.
Sabrina, ada ke?
First one, if it is recur again,
This
Alright,
meeting is
Doctor.
being
Thank you so much,
recorded.
Doctor. And
Okay.
happy weekend as well.
Okay.
Better.